Thank you. And I want to begin by thanking, of course, the committee. And I know many of you, but not actually all of you. So that's a good thing. I definitely want to thank Jennifer for moderating this and for inviting me to the panel, to my colleague Carol Levine for her wonderful presentation of our shared work. And I really want to mention the John A. Hartford Foundation, which of course is a critical funder of this committee, but was the funder of the Home Alone report and the subsequent focus articles that we had too. So I want to thank them. I also want to just mention in that introduction, as many of us have had, we've had many, many years in this work, and from many different perspectives. And so my interest in what you're talking about today around navigating the healthcare system does come from a nurse perspective to begin with, both as a visiting nurse. So you go into someone's home, I know others have heard me say this, you've had all this education and you're all primed up to be the expert and to help people, and then you go in the door and you go, oh my God, I'm the guest. These people are really dealing with it. So not just my education, I had great faculty that really kind of got the whole family thing, and I taught it, but I also worked in hospitals. And I chose the 3 to 11 shift because you would be with families. You would see people, as opposed to the early morning shift where you're like getting everybody ready for tests and all those kinds of things. So, I do get this culture thing, and I want to address it in these comments. Let me just make sure I can do this, okay. So these are my main points so you can get it right up front. The Home Alone report that you heard from Carol Levine, my cherished co-author in this, does show that people are doing a lot, and you heard that. The second thing, though, is as I've been moving past this study and trying to get into the policy and practice, as you heard, the translation of all of this, hospitals, nurses, and other healthcare professionals will say, but we already do that. We're doing this already. We have policies in place. No problem. Thank you for your study. Go away. That's basically the reaction that you get. Not everybody, but big. And so what is this disconnect? Because I am, as a nurse, as I said, lots of friends who are nurses, faculty, deans, all those things, and I believe them, I want to believe them. So what is this disconnect that begs for what you kept hearing about, culture change, but also policy. Policy helps culture change, and tools to help fuel. Pick up the pace. That's one of my favorite phrases now. Pick it up. Let's get going. So the Home Alone, it's not just the findings. I wanted to point this out. And we also had funding from the Langeloth Foundation. This was part of a bigger project on how professionals can join in with family caregivers, professionals supporting family caregivers. That's a whole other topic. But we did focus groups. We did focus groups with different Hispanic, African-American, both caregivers and nurses and social workers, by the way, to really try to dig into this. Actually, that was before we did the study, so it helped. AARP has been doing town halls all around the country. So if you want to believe, or if hospitals want to believe, or anyone, any of the service delivery system believes, nope, no problem, we're doing this, go to one of those town halls. It is unbelievable how visceral it is, and people saying, I'm not getting the help. You heard the panel, and you know this, but thousands of people come out within a day or two notice to talk about these things. And the reaction from the field is, as you heard from Carol, kind of, well, we kind of knew that, right? But wow, what should we be doing about this? So, but I feel it confirms little to no training of family caregivers, and I threw in guidance because in my discussions with Hawaii, the Hawaii State Office, they really said we should be careful about saying training, because family caregivers often feel that's nurses get training, doctors get training. I'm not going to be trained. They want guidance, instruction, those words. So I just want to put that out there, and I want to address it anyway. So we do it already. They believe it. So here's my observations on this, but I would encourage you to think about this too. First of all, some may do it. I want to believe that, and I do believe it. The nurses improving care of health system elders, we have a whole project working with them. And some of them really do, and some of them say, you know, I thought I was. So I believe it does, for many, come from an honest feeling that they're doing this. But I think what they're doing is they're answering questions. If someone says, how do I do this? Or what is this about? That then they will proceed and answer the question or maybe show something. But family caregivers often don't know what to ask. They're not all like Kathy. Right? By the way, that was a very compelling story. They're not all like that. And in our our focus groups around transitional care back in 2009. This is a direct quote, but you know it. We don't know what we don't know. So how would you know to ask? So that's part of this whole big disconnect. And that brings me to lacking anticipatory guidance. So I'm seeing Terry shake her head. Years ago, when we were in school, I don't think this is happening right now. So it gets back to what should we do? We were trained to anticipate, how to anticipate the needs of the patient. So you don't wait to be asked a question. This could be done in maternal child health. That's kind of where that came out of the literature. What is the new mother going to need to know before they walk out with this darling new baby? How do you feed them? How do you take care of them? How do you bathe them? That was all part of this anticipatory guidance, but it should be across the board, and I want to get back into that. Here's the other one. Policies are in the place. Joint Commission. We have the Medicare conditions of participation. This is going to be my next paper. My next project is going to be on this. So I can't give you all of it, but I have it, and you can ask me during the Q&A if you want. But I'll just take the Medicare conditions of participation, which are, they kind of go together. The focus is on discharge planning, not on guidance. It is not anticipatory. It starts if you are considered at risk of adverse health events upon you're screened to who's going to be at adverse risk. So first of all, who makes that decision? You have to have a policy in place. There's no guarantee that you're going to get any guidance in any of the current policies. And if you do it all, it's going to be there. There's no specifics around medical nursing tests. Not that that's the only thing you need to know. And discharge planning does not equal training. So when people say we have discharge plans in place, that is typically, well, we're going to refer to a home health agency, God willing. I wish there was more of that, frankly. It doesn't mean we're going to guide you, train you, figure out how you're going to get follow-up. So that's the disconnect, and what is needed are culture change, policy, and tools. Culture change, norms. I am also a sociologist. My doctorate's in sociology. So when we say culture change, you got to go into what is that? It's the belief systems, it's the language, it's a change that has to occur, not just through education. We can't just start teaching them now. We have to take existing healthcare professionals and really change the way they think. Anticipatory guidance has to be the norm. We have to think about, and I use the hospital, this guidance needs to occur throughout. I'm talking about the hospital right now, but anyone. Person's going to be discharged. The nurse, usually the one at the bedside, has to think, how are they going to get downstairs? When they're downstairs, who's got the car coming? How are they going to get from the car, from the wheelchair into the car? When they get home, what's happening? And then do they have to get upstairs? There's no visiting nurse waiting at this doorstep there with a home health aide. So how is all this going to happen? Do they have the equipment that they're going to need? All of that, someone has to think that through, because the family caregiver is not thinking about all this. They're still like, whoa, I got to take this one home. And then they might have to run back to work, by the way, as they do that, because most of them are working. So that's part of the norms, the culture that has to be given. And by the way, if you even try to do this, very quickly, my sister-in-law trying to prepare, she's a business person, for the return of her father-in-law from same-day surgery, her father from same-day surgery, called ahead of time, called the surgery center ahead of time. What is he gonna need? Can I pick up medications now? So that when my brother brings him home, probably later at night, that it will be all set up. She was trying to prepare the caring situation. We'll tell you when the doctor will tell you when you leave, right? He doesn't get discharged like 8 o'clock at night. Needed a sitz bath. We have to, that's even someone asking, begging to prepare and not getting help. AARP is on the case, as you can imagine. I have a minute. The Caregiver, the CARE Act. I don't know how many of you know about this, but it begins by asking the family member, the patient, if they would like to identify a family caregiver in the record. That is not in the Medicare conditions of participation, not in Joint Commission. You can't know who you're working with on discharge planning and training if you don't know who that person is, shift after shift after shift. There's gotta be in the record. There's other things going on. I won't go through this. I just want to point out that's not the only thing they're doing. This is the caregiver notifying the person, the family caregiver, we would like 24 hours ahead of time. That would be nice. Consultation, that they would be involved throughout the process, not just as you're walking out the door. And that there would be this training or guidance. If you're expected to do medical nursing tests, that you are given a demonstration of how to do it. If you don't want to, fine. So we're doing that. Whoops. I feel this would give ammunition to the nurses and what have you, like, I have to do this. It's not just I want to do it or my norms tell me to do it. It's the law. We have to do this, so you have to support me in this work. It's already been passed in New Jersey and Oklahoma. There are 7 more states that have introduced it. You can see that in the slide. It has triggered interest in practical tools. We had a roundtable in December. I won't get into it, but bringing caregiving and technology together. We have been funded to create videos to teach family. They don't exist, I can tell you this. No videos or any tools to help train in this area. So we'll be doing that. Of course, they'll go on our website. We would like them everywhere, and that's where you can find me. Sorry, it was 1 minute too long.
Thank you.
Thank you very much.
So now we'll hear from Dr. Delbanco.